In this session, we're going to cover the high-yield USMLE material commonly tested on the GI system. We're only going to focus on these topics, really the highest yield that there are. There are many other topics that are also commonly tested. We're not going to cover them in this video. Trying to make a follow-up video covering those. There are no disclosures. The first thing that we're going to talk about is pancreatitis. Pancreatitis, one thing examiners love to go after is that it's possible to get pancreatitis caused by gallstones, where they block the pancreas and so you get a pancreatitis. In this case, they may show the labs should have an elevated ALK phosphatase and also elevated LFTs. So if you see elevated ALK phosphatase and LFTs with pancreatitis, think it's related to the stones. The treatment over here is just going to be fluids. If you have pancreatitis caused by a medication, for example, valproate, it's usually a little less severe. Of course, pancreatitis usually affects alcohol drinkers. You may also have patients who have chronic pancreatitis. That's the image to the right. This is a CT scan of chronic pancreatitis. And what happens over there is you slowly, over time, the pancreas becomes more fibrotic and you slowly begin losing functions of the pancreas. So over time, you'll start having malabsorption, you'll have steatorrhea, you'll have a new onset diabetes. And that's because there is fibrosis going on in the pancreatic tissue. As the disease progresses, not only will you have chronic epigastric pain, but you have these calcifications. The labs, this is the laboratory to remind me, the labs in chronic pancreatitis are usually not going to have a very high amylase or lipase because the tissue is already destroyed. Regarding amylase and lipase is a lot more sensitive and specific for the pancreas because amylase is found in the mouth and saliva and other places. Pancreatic cancer, this is extremely high yield. The risk factor that you can change that will lower your risk the most is going to be to stop smoking. They may describe in the question stem someone who has pain when they're going to sleep at night. And the reason for that is the pancreas is a retroperitoneal organ, so when you're lying down, that's when you're kind of aware something's not right. They also very commonly have thrombophlebitis. This image over here is thrombophlebitis, the inflammation of the vein because of a little clot going on in there, and this is because you're hypercoagulable. This is not only seen with pancreatic cancer, don't be tricked by that. This is seen with other cancers as well. This is a hypercoagulable state. One topic that is also very high yield regarding pancreatic cancer is which imaging modality should you choose if you suspect someone has pancreatic cancer. And the answer to that really depends on where do you suspect the cancer is. So for example, if the cancer is at the head of the pancreas over here, then it will be blocking the gallbladder and the liver. They won't be able to drain down. And so signs of that will manifest as jaundice. So if you have a patient and you suspect pancreatic cancer and they also have jaundice, the tumor is most likely over here. However, if you have a patient who you suspect pancreatic cancer, but they don't have jaundice, the tumor is more likely back in the retroperitoneum. So which imaging modality should you choose? Well, if you have a patient with jaundice, so you suspect the tumor is at the over here at the head of the pancreas, then it's close to the abdominal wall. You can just grab an ultrasound and that is your best imaging modality. If you have a patient who you suspect that has pancreatic cancer and they don't have jaundice, then the tumor is more likely in the back, retroperitoneal. In that case, you'd like to do a CT scan. That would be the best imaging modality. Finally, there are palliative measures available for people with pancreatic cancer. One, you could do the gallbladder anastomosis to the jejunum, kind of bypass this whole area. You could put in a stent. So there are some options for palliative measures. Cirrhosis is, of course, a very high-yield topic. If you have a patient with cirrhosis, it's very likely they're a drinker. If they don't drink alcohol, the next most common thing is going to be chronic hepatitis, for example, Hep C, so a viral reason for having the cirrhosis. They may present to you an image like this. This is a hepatic hydrothorax. These are more common on the right side because the liver it is communicating through the diaphragm. The fluid is going up here, and so you have that hepatic hydrothorax. With cirrhosis, you can also get hepatic encephalopathy. With hepatic encephalopathy, one thing that you'd like to do is look for the source. Why does this patient have hepatic encephalopathy? So for example, patients with cirrhosis commonly can get upper GI bleeds. And if you have an upper GI bleed, the blood has time to be reabsorbed in the intestines, and so the BUN and creatinine go up, also raising the ammonia level. And so that could, for example, be one source of why you have hepatic encephalopathy, and the treatment would be lactulose or rifaximin. Down here is the spider. This is actually a peacock spider, a really interesting insect, but it's here to remind that spider angiomatas are caused by the high estrogen state. Next, gallbladder disease. This is a very broad topic. We'll try to cover the main points here. The first, the gallbladder drains through the cystic duct. Up here you have your liver and the hepatic duct, and they both connect to form the common bile duct, draining out of the ampulla of Vater. If you were to have a stone over here, this is cholecystitis. A stone over here is choledocho, and over here is cholangitis. Cholecystitis, this of course is the stone is blocking the gallbladder. You should ideally remove this within 72 hours. If you have a stone over here, we said is cholangitis. This is when you have Charcot's triad of right upper quadrant pain, fever, and jaundice. And they may also describe a patient who's in the ICU, who has a fever of unknown origin. And you take a look at the patient and you press the right upper quadrant and the patient grimaces. Well, you should be suspecting a acalculous cholecystitis, cholecystitis without any stones actually causing it. The treatment for this is going to be the percutaneous drainage, antibiotics, and when you're able to, you'd like to remove that gallbladder. You can also have patients who are on parental nutrition. When you have parental nutrition, there's no stimulation for CCK to contract the gallbladder, and so that predisposes you to forming stones. Rapid weight loss also predisposes you to forming stones. And something examiners love to say is if you find some stones in an asymptomatic patient, what's the next best step? And the next step is to just reassure the patient, and you don't really treat them if they're asymptomatic. You may also be presented with a patient who has right upper quadrant pain and right shoulder pain, but the pain usually just happens after meals. It lasts for a few hours. It's intermittent. This describes biliary colic, and the important defining factor here is that it's intermittent and it only comes on after meals, and it goes away after a few hours. Esophageal perforation, this is a very high yield topic. It's an extremely dangerous condition. You can get it after endoscopic procedures. You can get it from Boerhaave syndrome. And you see over here, this is the widened mediastinum because there's air in the mediastinum. The best study to see this is a contrast esophagram where you're going to see some of the contrast spilling out in the area where the perforation is. Over here I have a bunny rabbit with red eyes that's eating. The red eyes is to remind me that the patient may be described as having infected conjunctiva. Of course, you get the red eye because they're retching and vomiting and coughing up so much. And the eating is to remind me that you may have salivary amylase and food particles within this fluid. So if they take a sample of that, they may ask, what do you see inside this fluid? The answer would be the amylase and food particles. Ulcerative colitis, you have the inflammation of the top layers of the colon, and classically they describe crypt abscesses is the buzzword over here, has a bimodal distribution. This screen over here is to remind me what you need to screen for with ulcerative colitis. Although you have an increased risk for primary sclerosing cholangitis leading to cholangiosarcoma, the real thing that you're screening for is colon cancer. They have an increased risk for colon cancer. I think it's 8 years after you see the diagnosis, you're supposed to do a colonoscopy, and then every other year you check them out. Over here is an image of toxic megacolon. This, of course, is the feared complication of ulcerative colitis. And the reason for this, the pathophysiology, is that you're destroying the top layers. And so if you lose the muscle and the nerves, then there's no way for the colon to contract and become a little smaller. The same thing happens with C. diff, where you lose those top layers, and so it expands. Spontaneous bacterial peritonitis, this is going to be the last topic we cover. This is a patient, usually with liver disease, who comes in abdominal pain, and they like you to know that you should treat these patients prophylactically. Before you even wait for the labs to get back, you'd like to treat them, particularly with a third-generation cephalosporin or fluoroquinolone. Over here I have the 350 cent to remind me that the 250, the difference between these guys, 250 bacteria within the fluid is diagnostic of bacterial peritonitis. I hope this was useful. If you found it helpful, please let me know. If you have any questions, feel free to reach out, and I'd be happy to answer them as soon as I can.